discussion that revolves around service delivery. Our topic this week is scaling up the access of contraceptive services and products in the last mile communities through training of community health workers. My name is Joshua Mushwakotere, and with me here are two professionals who are here to help us demystify contraception or birth control. Mr. Paul Atwine, the Marketing and Communications Officer from Health Entrepreneurs, Uganda, and Dr. Deogracious Migade, the Senior Medical Officer, Reproductive and Infant Health Division at the Ministry of Health. Welcome, gentlemen.
Thank you, Josh.
Thank you.
I think I'll start with the doctor. Doctor, what are the national policy guidelines and service standards for sexual and reproductive health and rights?
Okay, so thank you, Joshua. Providing quality reproductive health services requires guidance on evidence-based and clinical practice to health workers. So as Minister of Health, we've come up with national policy guidelines and service standards for providing sexual and reproductive health and rights. And based on incoming evidence, these have been updated to include provision of family planning, especially by the community health workers. These provide an overarching guidance and clearing on who provides a service, when, and who gets the service, and under what environment these services are provided for. We have various documents that have been finalized and others which are in the pipeline. We know as a country we are in the process of finalizing our sexual and reproductive health policy, which is now at cabinet level. But we have had these policy guidelines in existence right from 2006. And 2010 we updated them to include the provision of FP by the community health workers, which we call the VHTs. Yeah.
All right, thank you, Doctor. I think my next question goes to you, Mr. Atwine. Since the government has already provided all sorts of services, I think first you need to help us understand what Health Entrepreneurs really does in Uganda.
Thank you. Thank you, Joshua, for that question. Health Entrepreneurs is a social enterprise that provides primary, affordable and accessible primary health care to communities in the last mile meaning the rural setting, and we do so through training VHTs or community health workers to provide that service. They are supported by a call center via a toll-free line of medics that help them diagnose, and they are also supplied with medicine that they can provide to the community at an affordable and sustainable rate.
Right, thank you. One may ask, community health workers have already been trained through various government programs. So why the need for this further training?
One thing, the shelf life for any training is about 7 days. So it requires, one, that they constantly receive refresher trainings, but also some of these services that they provide, there are updates that keep coming in terms of policy, in terms of how they should provide the service, or even there might be innovations that have come that they need training on. Another important thing is that now in this day and age, climate change was not as serious as, or the impact that it had on the communities was not as bad as it was right now. So it also helps them in the sense of resilience. So they are able to prescribe and recommend to the community from a health perspective, whether it's in nutrition or anything of the sort, how they can be more resilient and mitigate some of the negative effects on their health and the environment that may come due to climate. So that's why training is equally important.
So, Doctor, what prompted the community-based approach to scaling up access to contraceptive services in rural settings?
Okay, thank you, Joshua. So using VHTs, we call the village health teams. These are our primary health care providers in the communities who know they live within the communities. They are within communities. So as one of the commitments that the country has undertaken to improve access to quality and voluntary family planning methods, we thought that taking on the village health teams to provide some of these family planning commodities, what we call the short-term methods, would be one of the many strategies, one of the various strategies that we have under this objective. And this will ensure that if they are providing the services in the communities, they bridge the gap. Because you know some of the reasons why we still have a high unmet need for family planning, why some of these people are not accessing family planning services could be the distance. They have challenges with coming to health facilities. Using these VHTs can help bridge that gap, but also follow up on some of already existing clients who are on family planning and who could be reporting some of these issues which are not addressed in communities. So they provide an important linkage between our health facilities and the clients in the communities who may need these family planning methods. Yeah.
All right. Going back to you, Mr. Atwini, has there been a surge in demand for contraceptive methods following the trainings of these community health workers?
Actually, yes, there has been. Just getting some stats from 2020 and 2021, we all know the lockdown period is one of those periods that really tested the healthcare system in Uganda. But for example, the self-injectables like Cyanapris, as of 2020, the demand was at 36%, but by 2021, it went to 69%. And the reason is because some of these contraceptive methods offer women in the rural setting the ability to choose when to have their next child. And they come with the kind of discretion that won't attract unintended consequences like domestic violence from their partners, where the partner would find the contraceptive pills somewhere and be like, why are you taking contraception? What are you trying to do? But so there's been a huge intake, and also impact-wise, it is significantly reduced on the number of unintended pregnancies, the number of unwanted pregnancies, and the possible abortions that might have come out of people having been exposed to episodes where they used unprotected sex. They're able to take emergency pills, and that overall reduces the strain on the healthcare system of the long term.
Right. So my next question to both of you will revolve around the FP 2030, but for people who are not really well versed with the FP 2030, kindly let us know, Doctor, about what this FP 2030 is.
Okay. So family planning 2030 commitments, these are set of objectives that the country has committed to in line with our national policies and also vision. We have aligned this with National Development Plan 3, and the goal is to ensure that by 2030, the population enjoys quality reproductive health services in order to improve quality of life, but also enhance productivity. We know as Ministry of Health, we've been clustered with other sectors, and the overall goal is to improve productivity in the population, what we call human capital development. So this commitment contributes to that. In addition to quality life, but also want a population which is productive. And the set of objectives that the country has set out and committed to, with clear strategies that have been set to ensure that we have these attained by 2030. Yeah.
Okay. And how on track are we to achieving this family planning 2030?
Okay, yes. So the country is on track to achieve FP 2030 commitments We have 6 objectives, but I could briefly go through what and where and what we've done so far. The first objective is to improve access to quality FP commodities, but also voluntary provision to the clients. And very many strategies have been laid, but I would put emphasis on the one that we're discussing currently, going out to the communities. We know we want to go beyond the health facilities. We want to ensure that the people out there in the communities have access, and that's one of the basis why, together with partners, colleagues like the health entrepreneurs, we are empowering the VHTs to be able to provide this. And this is a key milestone in ensuring that this objective is attained. The second objective in the FP 2030 commodities on improving financing for adolescent health in the country. We know our population, that a big population of our country are adolescents and young infants below 24 years, and they have very many issues to do with reproductive health. What I can report on right now under Ministry of Health is an independent division of adolescent health, and there's a lot of advocacy to ensure that we have more funding for adolescents and also information about that. We have the adolescent health policy that is being finalized. The third area on family planning commodities, ensuring increase in family planning and also availability. As Ministry of Health, we have already delivered a commitment letter to national medical stores to ensure that at least 25% of the financing for reproductive health commodities is directed towards family planning commodities. And our target is to ensure that by 2030 we ring-fence this to 50%. Other areas where we are making progress on having a policy environment that supports family planning. We are finalizing the section reproductive health policy, which is at now cabinet level, and we are fast tracking on its approval and dissemination, but most important also implementation. We also want to ensure that we have data use at all levels. We're collecting a lot of data on family planning, but we have to ensure that it is analyzed and presented at different levels, speaking to whatever level we are presenting to. We are using different innovations, infographics, data analysis to ensure that we inform actions in family planning. And lastly, but most important, on the key objective is the issue of addressing myths and misconceptions. We know that one of the barriers to uptake of family planning is the myths out there in the communication, in the communities, and the misconceptions. And a lot of effort has been deliberately put in this area. We are working a lot with partners. We know that a lot is generated from the facilities itself, giving time to these clients who are getting family planning, attending to these clients, and also in the communities, ensuring that we provide knowledge, we provide information to people in the communities, but also bringing on board other key stakeholders, our religious leaders, cultural leaders, to ensure that they also be part of this agenda that we are pushing. Thank you.
Healthy entrepreneurs. You talk about training these community health workers, but what criteria is used to select the candidates for these trainings, and what are some of the safeguards?
Okay, one, like I said, the person has to be a VHT. They have to have a minimum of 3 years experience as a VHT, and also they have to have demonstrated in that whatever period they've been a VHT, a stellar record in terms of service delivery, but also their rapport and reputation in the community is equally important. Trust is a very key component of this interpersonal relationship that the VHTs have with the community. So whoever is providing the service surely must be someone that is trusted by the community members. Then within our model, because again, one of the things we do is to incentivize them to actually scale up this service and make sure it's accessible and it's widely distributed within their community, is we try to ensure that they are committed to the model, the HA model, and the entrepreneurial mindset that they do. They do not charge specifically for provision of cyanide breast, but their investment comes in terms of the 3 days they come for the family planning trainings, them attending the refreshers that we have monthly on some of the methods and some of the innovations that have come, and their transport to come for these meetings.
And in these trainings, what are some of the hurdles or challenges you faced while trying to provide these services?
Well, I think the first and the most key is most of the current pool of VHTs that we onboarded when we started operations in Uganda are now old, and at least my colleague can confirm that most of the VHTs are in their senior years, and that comes with experience, which makes them more effective, but then also it affects how much they can retain in terms of information. So training becomes a bit more, it requires a bit more to be done more regularly, which can be a bit of an issue when you consider the resources of having these refreshers often. And then also earlier you mentioned something about safeguards. We give them mobile phones, and in those mobile phones there's an health hub that comes with a screening tool, so they do not operate unsupervised or unguided. The screening tool helps them do that, but they also have the support of a call center that is able to guide them if there are any issues, or if the client that they are serving may prefer a more permanent method or something more effective than what they are giving.
Back to you, Doctor.
Yes.
About this family planning 2030. We have healthy entrepreneurs here. This collaboration, because you talked about working with private sector partners, how has this collaboration with these private sector partners, like healthy entrepreneurs, contributed to reaching the national goal or targets?
Okay, yes, thank you. Yes, so of course you said in the FP 2030 commitments, we have different objectives, and different partners are contributing to these different objectives. For example, Health Entrepreneurs is working closely with the village health teams, which is contributing to our first objective of increasing access to family planning commodities. But you know that there are very many other partners which are contributing to the different areas. A lot of people are doing a lot of work in data utilization. We have talked about myths and misconceptions. There's a lot of work that is being done in social and behavior change, because we know we need to work a lot on behavior and also information, embedding information there. So we think that for us to achieve our goal, we need to work closely with everyone and to have all our efforts brought together and also in a coordinated way in order to achieve and also complete the goals that we've set for 2030. Yeah, thank you.
Well, you talked about the myths and misinformation about contraceptives and birth control methods. There's so many communities or different societies that look at contraceptives as something of, let's say, it's a controversial one. I wouldn't want to use the specific terms they usually call it, but they call it ungodly or evil, all sorts of things. How are we prepared to deal with such communities?
Okay, thank you. Of course, that is that's an interesting area. Like you've said, very many societies or communities may term it. But I think one thing that we need to appreciate is that this is birth control, not birth prevention. Everyone needs birth control for health, life, quality living, and also having a family, having a child when you're ready, and having the right number of people we need. Now, for whatever method that we may talk about, even for the different societies that, like we've said, are terming the different terminologies, there's a form of birth control that maybe they can accept. So I think that is the entry point. that we need some form of birth control. And then for the misinformation that keeps coming up, of course there are different reasons. One of them is reported or assumed effects, side effects. So this starts from us, the health workers. We need to equip these health workers with ability to give the clients enough knowledge and also handle whatever issues that the client may come up with. But at the same time, in the communities and among the people, we need to have information passed on to these people to give them, the clients, enough information about the services that we're providing and provide what we call a method mix. We are not speaking to one family planning method, but we have to provide a range of options so that clients can choose voluntarily which option they choose and based on the information that has been provided. Yeah.
All right. Thank you, Doctor.
Welcome.
We slowly getting to the close of this show, but before we go, I would like you to also talk about the economics of
Okay, so
how does it affect the, let's say, household income or the economy in just 1 minute?
Okay, so the first thing is our model as health entrepreneurs is meant to alleviate the costs of transport and consultation of the doctor, that comes with accessing quality and affordable primary health care. On top of that, the end users or the consumers in the rural settings are also receiving medicine at a much more affordable rate from our PhDs. So to improve their livelihoods, you need to make sure that health is affordable and they have more disposable income to meet their needs as a household. Now, what does it mean when you're not empowering communities with the ability to space their children? It means that if a mother has given birth and she's breastfeeding, she has her nutritional needs, the child has nutritional needs, and research has proved that the first 3 days after giving birth is the time when most mothers receive the full range of optimal nutrition that they need. They are spoiled with all manner of feeding. But when a month passes, the care and attention shifts to the child. So the mother is not getting as much nutrition as she would need but remember, she's breastfeeding. Now, if down the road, the head of the house says, I want another child, that means that now she's carrying a child, she's breastfeeding, and she also has her own nutritional needs. Now, those are 3 lives affected. Chances are that, God forbid, this next child that she's carrying, due to nutritional deficiencies, the child may be stunted or something like that. And that circle affects the child's development of mind. That means that we're getting into the workforce years down the road. We're getting children that from the onset have not fully realized their mental capacity to excel in class, and then also their productivity is affected. So the workforce that we're getting down the road is not at 100%. So you can see you're straining the health system, but also you're getting a workforce that's not going to fully benefit. And he said this, my colleague from Ministry of Health said the same thing. Having an optimal workforce, it starts from being able to allow mothers to space the children so that the recommended time, they call it the first 1,000 days, should be 3 years most before they have the next child.
Thank you so much, gentlemen. Now we continue with the conversation on the Twitter Spaces. The hashtag is GCIC Baraza, and we do this every single Friday, starting from 10 a.m. to midday. Please do join us. We will be live every single Friday, 10 a.m. to midday on YouTube and Twitter as well. So we're getting into the Q&A. I have Doctor with me here and Mr. Paul Atwine from Healthy Entrepreneurs, and they'll be taking in your questions. Thank you so much for listening in. Now we're going to get into the Q&A session.